Hello, and welcome to the University of Miami's Comprehensive Center for Brain Health. This is our first webinar, our first annual webinar on healthy brain aging and prevention of dementia. So welcome. We are happy to have you all here with us today. I'm Dr. Amy Rosenfeld, physical therapist researcher, and I'm part of the interdisciplinary team here at the CCBH. I will be your moderator for today's webinar. Let's go over the agenda for today. First, you'll be hearing from world-renowned researcher on memory and cognition, neurologist, expert in Lewy body dementia, and founding director of the Comprehensive Center for Brain Health, Dr. James Galvin. He'll be presenting opportunities that we can all take advantage of to make our brains healthier. After that, we'll take a brief break, and when we return, I will lead a short session on gentle Tai Chi stretches. Then you'll be meeting the team and learning from our team about research opportunities we have to offer. Dr. Galvin and the entire team are all here live. You will probably have questions for Dr. Galvin or any one of us. So at any time, please type your questions into the Q&A on your Zoom. We'll be addressing your questions in the live question and answer session at the end of the webinar. So join us as Dr. Galvin speaks about healthy brain aging and prevention of dementia.
Hello, my name is Dr. James Galvin, and I am the founding director and principal investigator for the Comprehensive Center for Brain Health in the Department of Neurology at the University of Miami Miller School of Medicine. I am delighted to welcome you to our first of many seminars on healthy brain aging and the prevention of dementia. Our entire faculty and staff at CCBH are truly excited to be back and provide you opportunities for participation in one of our many cutting-edge research programs. You will have the opportunity to meet the entire faculty and staff during the seminar, and we'll be holding a Q&A session at the end. We look forward to seeing you at our state-of-the-art research center, which will be opening soon in Boca Raton, Florida. Today, I'm going to talk about healthy brain aging and dementia prevention. I'm going to show you a lot of research data, which has been supported by numerous grants from the National Institutes of Health, the Leo and Ann Albert Charitable Trust, the Harry T. Mangurian Foundation, the Lewy Body Dementia Association, and the Florida Department of Health. I'd like to thank all of our sponsors and donors for providing the funds to do this truly innovative and cutting-edge research. We are one of the largest funded operations in the entire state of Florida. So really excited to be able to share with you this data over the next 20 minutes or so. Before I start, again, I'd like to acknowledge all of our collaborators across the country and around the world who have contributed to our research efforts. I'd like to go over a couple of learning objectives. One, we're going to discuss the differences between primary, secondary, and tertiary prevention strategies. It's important to understand the differences so when we talk about the different research programs that are available, you can understand which program is the best for you to participate in. I'm going to talk about the role that resilience and vulnerability factors play in brain health and neurodegenerative diseases, and some of the challenges that exist in measuring these factors. I'll also talk about the strategies that we have developed to actually address this important problem. And last, I want to describe some of the ongoing and planned brain health and dementia prevention studies that are going on in our center. First, let's talk a little bit about the concept of dementia prevention. This is really a relationship between increasing age, changes in cognitive abilities, and accumulating pathology. So on this graph, we can see plotted on the y-axis is cognitive function, and on the x-axis is age. Now, when we think about the concept of primary prevention, these are people who have no symptoms and no pathology. So on this model, this would be somewhere between birth and mid-40s. And the concept of primary prevention is you want to try to prevent the onset of disease before there's any evidence of disease or injury. That is, you want to reduce the incidence of the disease. So people in this group would be people who have no cognitive impairment at all, or maybe have some subjective complaints. The next phase is secondary prevention. And hypothetically, this would begin in the mid-40s and go into the mid-60s. Secondary prevention is to reduce the impact of disease or injury that has already started. Okay, so there's already the beginnings of some pathology, and we're trying to reduce the prevalence of the disease appearing. Okay, and so examples of this would be something called preclinical Alzheimer's disease. So these are people who are cognitively normal, but in their brains, they have some evidence of Alzheimer's disease or other types of neurodegenerative diseases. Or people with early mild cognitive impairment. So the first noticeable objective findings. Last, we have the concept of tertiary prevention. And this is when the disease has already started. And what we're trying to do is arrest or halt the progress of an established disease and really reduce the disability and disablement that comes from the disease. And so these would be people in the later stages of mild cognitive impairment and people who have clinical Alzheimer's disease or related disorders. So very different strategies, right? And it's important because our tactical approaches to these strategies are going to be different depending on what stage someone's in. This opens up the possibility of understanding windows of opportunity. So this was a study we published this past year where we did both MRI and PET scans to look at amyloid pathology. Amyloid is the protein that forms in the senile plaques of Alzheimer's disease. And so what we found were when we studied 3 groups of people who were amyloid negative, they had no amyloid at all in their brain. At the far end of the spectrum, people who were amyloid positive, they had sufficient amyloid in their brain to be considered Alzheimer's disease. And people in the middle, that they were starting to accumulate amyloid, but did not reach that threshold for calling it Alzheimer's disease. And when we looked at the different measures of MRI metrics that we could measure, what we found was this relationship that between amyloid negative and amyloid intermediate people, and then between amyloid intermediate people and people who had amyloid positivity. And you could see that we had either, depending on the metric, either a sort of a upside down triangle or a U-shaped type of curve. And what we found was that the transition between amyloid negative and amyloid intermediate people, this showed signs of neuronal injury and inflammation. However, when we looked at the changes that occurred from amyloid intermediate to amyloid positive people, these metrics showed us signs of neuronal death or neurodegeneration. So this really gives us an opportunity, right? So if we wanted to attack a primary or secondary prevention approach, we'd really like to get people here where we can start to address the causes of neuronal injury and try to halt them before they lead to neuronal death. If we see people at this side, we're really on the tertiary prevention side, where we're trying to limit the disability, limit the problems that people have, but we may not be able to reverse some of the damage that's done. So we have 2 different types of windows, and that's very important for how we design our studies. We have done a lot of data looking at people that we follow longitudinally. And so these are just some graphs from different studies. And so in each of the graphs, we're studying people, for example, who had Alzheimer's versus healthy controls, or people with Parkinson's disease versus healthy controls, or people with Lewy body dementia versus healthy controls. And in each case, we find that if we follow people over time, so if you follow healthy controls over time, there's really very little change in their cognitive performance. But if you follow people that eventually develop Alzheimer's disease or Parkinson's disease or Lewy body dementia, okay, that somewhere between 2 and 4 years before they develop the clinical symptoms, they are actually showing some change, okay? So even though they're scoring in the normal range, their performance is starting to decline and accelerate. So just like in the previous slide, I showed you looking at MRIs and PET scans, we had these windows. using our clinical tools, we also have these important windows. And these windows are important because they give us a chance to offer research opportunities to try to halt the disease in its tracks. And if we catch it early enough, potentially reverse some of the changes that are occurring. From our research, we know that there are predictors of people who are beginning to develop the changes in their brain suggestive of Alzheimer's disease or related disorders, and who may go on to eventually convert or transition to become symptomatic. So, for example, people who have very early changes in their judgment and their problem-solving abilities. These difficulties may occur years before any noticeable memory changes, like forgetfulness. So this is a very early clue that we can use, and I'll show you how we're designing tests to pick this up. We can also look at very early visual, perceptual, and attention changes. This also may occur well before the classic memory decline that we think about for Alzheimer's disease. When we give people tests, typically if you've done a test and you repeat the same test every time, each time you do it, you should get a little better. That's called a practice effect. What we found is people who have evidence of pathology in their brain, they actually lose this practice effect. They lose this ability to gain from experience. And this can be a very sensitive early sign of disease. People who in late life show signs of depression or psychomotor slowing, slowed thinking. This may be an early warning sign. People who have changes in their physical abilities and physical performance, such as walking slower, having declining ability to do their physical activities, show sarcopenia, which is the loss of muscle mass and strength. All of these things suggest that there may be early signs of disease that we could intervene. And last, increased inflammation. So all of these things we can then use to design a program to try to improve people's brain health. We can do this by building a model. As a scientist, models are very helpful because they help us sort of lay out the way we think about how the disease is occurring and what kind of programs could be done to attack different stages of the disease. So as a neurologist, when people come to see me and they have Alzheimer's disease or some other dementia, I've diagnosed them. So they have the clinical expression of the disease. But before that, they're having some cognitive decline, some changes that are eventually going to bring them to the doctor. And this may occur again, 2 to 3 to 4, up to 5 years before people are actually diagnosed. Before that, however, they have some signs of change in their brain. So they have that neuronal injury and that neurodegeneration. And that may be occurring another 5 to 10 years before people develop cognitive decline. However, before that, if they have Alzheimer's disease, they're depositing plaques and tangles. And this may occur up to 20 years before people are diagnosed. So if we think about this pathology and it's beginning 20 years before, we can start to think about, well, what are the risk factors for plaques and tangles? So let's call that risk factor A. That's the plaque and tangle group of risk factors. But we also know that when we look at the brains of people when they come to autopsy, is that there aren't just plaques and tangles. There are lots of other pathologies. There's microvascular changes, there's Lewy bodies, there's inflammatory changes. So these are other pathologies. Well, if there are other pathologies, then by definition, they probably have other risk factors. So let's call that risk factor B. So if we wanted to design a prevention program for Alzheimer's disease and related disorders, what we'd like to do is to either address the plaque and tangle pathology, and many pharmaceutical companies are doing this by designing drugs that try to remove amyloid and tau proteins, the proteins that make up plaques and tangles. Our approach is to think about these other pathologies and mechanisms that are affecting neurodegeneration, because I think that these are more modifiable than we could approach from a lifestyle approach. Right? And we could empower people to take charge of their brain health. From our research, we know that there are a number of risk and protective factors, right? Which going forward, we're going to call resilience factors if they're protective, or vulnerability factors if they're risk factors. Now, within these factors, we know that some are not modifiable. There's nothing we can do to change these. So for example, age, sex, your genetics, we can't change that. It's not modifiable. But there are a whole host of factors that we can potentially modify. So if we look at risk factors, low educational attainment, not using your brain, is a risk factor. Obesity, increased body mass index, is a risk factor. Diabetes, sleep disorders like obstructive sleep apnea, depression, dyslipidemia like high cholesterol, hypertension, traumatic brain injury, smoking, drinking, hearing loss. These are all risk factors that potentially are modifiable. And if we can modify these appropriately, we can try to reduce the risk of developing diseases like Alzheimer's disease. We also know from the literature that there are a whole host of factors that seem to protect the brain. So staying physically active, cognitively active, socially active, being mindful, and eating a healthy and balanced diet. These things we can directly take charge of and control. And if we could do this in an appropriate fashion, we might be able to reduce the risk of developing diseases like Alzheimer's disease. What's really important is that up to 40% of the risk of Alzheimer's disease can be explained by factors that are potentially modifiable. Now think about that. Up just a little less than half of the risk of developing Alzheimer's disease may be due to things that you can directly control. So if we could design a program that can give you the chance to control these factors, you might be able to reduce your risk of developing disease. And if you have some symptoms, reduce the impact of those symptoms. So what are our approaches? What are our tactical approaches, right? So I talked about our strategies, primary, secondary, and tertiary prevention. So how do we go about doing that? Well, in all of our prevention programs and brain health programs, we use 4 basic approaches. The first is risk reduction, okay? So we try to reduce the frequency or severity of factors that can lead to poor health. So for example, if you're a smoker, we want you to stop smoking, okay? That's a risk reduction. 2 is we can do health promotion. This is enable people to take control over their life to improve their health. So if you don't exercise, we want you to start exercising. If you already exercise, we want to change or alter your exercise regimen to make the most that you can get out of it. The next is helpful behavioral change. That is changing people's habits to make the healthy choice the easy choice, okay? So for example, altering nutritional patterns. So changing the way you eat to make better choices, right? To choose fresh or whole foods as opposed to processed foods. And the last is to manage comorbid conditions. So this is the early detection and treatment of conditions that can contribute to brain disease. So for example, recognizing the early signs of insulin resistance or diabetes. Diabetes after age may be one of the strongest risk factors for Alzheimer's disease. So if we can reduce the risk of getting a diabetes, or if you have diabetes, get the diabetes under tight control, we might be able to reduce the future effects it would have on brain health. So this is an example of how people are trying to do this in other places. So this is something called the FINGER study. This is a study that's done in Finland. The F in FINGER stands for Finland. There's also a worldwide FINGER study that's promoted by the Alzheimer's Association. And what this study basically does is take all of these risk factors and protective factors that I just talked about that are well established in the literature, both by studies that we've conducted as well as studies done by people around the world, right? And say, well, if we could reduce the risk factors and promote the protective factors, we might be able to reduce the risk of dementia. So what they've done is that everybody who comes into the project is randomized to either getting regular health advice or to undergo this intense intervention where they're getting nutritional counseling and physical activity and cognitive training and managing their medical conditions, right? So everybody gets the same exact intervention. And that sounds great, except if you think about it, not everybody is exactly the same. So let's think about this. So I'm going to make you all scientists for the moment, right? And you have a lab. And in your lab, you're trying to discover a new therapy. And so you have models in the lab that help you test this. So you might use cells or you might use animals like transgenic mice. Now, the thing about cells or transgenic mice is they are in fact clones of each other. They're identical. You control everything about the conditions. You control the light, the food, the interventions that you give them, and genetically, they're identical. And so if you have a group where you're giving one intervention and the other arm is getting a placebo or a sugar pill, then if you find differences between these two groups, the effect has to be due to the drug, because that's the only thing that's different. And if there's no difference, then the drug had no effect. However, people are different. They're not clones of each other. And in fact, all people are different. And we have a fancy term for this. It's called the heterogeneity of treatment effect, which means that everybody responds differently to things you do to them. So now, if you take the same experiment where everybody gets either the same intervention or a placebo, if there are differences, the effect is likely due to the drug, but some people may not respond, right? Think about this. If everybody responded to this in drugs to the same way, we'd only need one drug for each disease, right? We'd only need one drug for hypertension, and everybody could take it and everybody's hypertension would get better. But that's not the way it works. Some people don't respond. They don't tolerate the medicine. They don't get better from the medicine. Some people get worse from the medicine. Also, you could do this whole study and say, well, we don't see any benefit, but yet there are people who were treated that actually got better. So they did respond, but only in certain people. So this made us start to think, well, instead of doing this big giant group design where everybody gets the same thing, why not try to personalize the approach, right? And target the approach to each individual based on their individual risk profile. So this set up with a bunch of challenges. So I talked about all these resilience and vulnerability factors, and we want to target it for each individual. So how do we actually measure this? How do we measure what people are doing before they come to see us? How do we measure whether they've gained anything from doing the intervention that we give them? What is the right dose? What's the dose of physical activity that people need to get a beneficial effect? So then, knowing all this, then how do we design a program, and how do we determine what's the best way to measure these things? So we've done a lot of effort, particularly over the last 2 years, in trying to figure out how we tackle this important problem. So the first thing is, how do we collect information? Well, we could do very extensive testing. And in fact, when you come to see us at the research center, you do get a lot of testing. We do a lot of testing. But the fact is that's not really practical in the clinical setting. So if we want to generalize our research to, clinical practice, we can't have people do 12 hours of tests. It's not going to work. People aren't going to be able to do that. So we try to think about how we could collect quick ways of assessing people. So one of the things we did was develop this tool called the Quick Dementia Rating System. So this is a brief 10-item multiple choice questionnaire that can be filled out by the patient, or it can be filled out by an informant, someone who knows the patient very well, like the spouse or an adult child. And so these are the questions. I know they're a little hard to see. I'll blow them up in a second, but there's 10 different domains. There's a memory domain, there's an orientation domain, a problem-solving domain, and activities outside the home, activities inside the home, toileting and personal hygiene, behavior and personality, language and communications, mood and attention. And these 10 domains really tell us a lot about how a person's brain is functioning, right? So we can give them a set of questions. And so we ask them to rate themselves, or for the spouse to rate their loved one, on each of these domains using these 5 categories. So for example, for memory, that there's no obvious memory loss, or there's consistent mild forgetfulness, or is there mild to moderate memory loss, moderate to severe memory loss, or severe memory loss. And we basically add up the scores for each of these domains, for memory, for the decision making, and then we can come up with a total score. And the beauty of this is that simple little 10-item questionnaire by itself can correctly pick up 88% of people who have a cognitive impairment. Think about this. 3 minutes, 10 multiple choice questions can pick up 88% of people who have a cognitive problem. We could really advance research, right, and improve clinical care if we could apply this in clinical practice. And in fact, we have a grant from NIH to exactly do this, to embed the QDRS into the health records of 10,000 individuals across 2 states and see if this improves their health outcomes. Remember, I talked about low educational attainment as being a risk factor. Well, the flip side of that is something called cognitive reserve. Okay, so cognitive reserve is basically how much your brain can tolerate pathology before it shows any effects. There's no clear agreement on how to measure that, but if low education is a risk factor, then higher education should be a protective factor. But education is not really an equal opportunity, right? So some people live in areas where the education system may not be as good as others. Other people, because of economic opportunities, may not be able to pursue higher education. So one other way of looking at it is your occupational attainment. So what job did you do for most of your life? And so what we did was we actually combined this approach using a very old 1950s tool called the Hollinshead Index of Social Position. So this was developed to look at socioeconomic status, and it looked at head of household. Well, we flipped it a little bit and take you as an individual and look at your highest education and your lifelong occupation category. And we're able to create a scale that ranges from 0 to 66 that gives us a way of looking at cognitive reserve. Okay, so this gives us some direct measure of how well your brain might be able to resist pathology, right, and preserve your cognitive abilities as you get older. What about physical activity? We know that over 31 million Americans are physically inactive, and that impaired physical activity really interferes with your health and your ability to do your everyday activities. Now, we can objectively capture this. We can have you do a whole bunch of things and say, this is your physical performance level. But when the first time I meet you, I'd love to get a sense of what you're actually doing, how much physical activity you're actually doing. So we created a scale called the Quick Physical Activity Rating, or QPAR. And this allows us to actually measure a dose of physical activity. And so here's the scale, and it's got a number of categories. And we can capture the intensity of an activity, the frequency, how often you do it, and the duration, how long you do it for. So if we multiply intensity times frequency times duration and add that all up, we can actually get a dose. And this is very powerful because now we can compare everybody to everybody because there's all sorts of activities here. So you might be someone who does mild activities, but do it very frequently. Or you could do someone who does a very strenuous activity, but does it very infrequently. How do we compare those two people? Well, this allows us to put everybody on the same scale. It's a very powerful tool. What's nice about it is this brief tool has a very high correspondence to all measures of physical activity. No matter what way we measure physical activity, people are very good at reporting their activities, and that score, that dose, reflects what they actually can do. So the first time we meet you at the research center, we can actually design a program based on what you tell us that you're already doing. So really helpful. What about cognitive activities? Again, if you read books, that's great. If you go to a bridge club, that's great. How do I compare a person who reads books to a person who goes to a bridge club to a person who attends the opera, right? They're all cognitive and leisure activities, but how do I compare that? Well, we created a scale called the Cognitive and Leisure Activity Scale to do that. And again, it allows us to create a dose of cognitive activities. Again, same principle. We have a group of activities and we have how frequently you do these activities over the past year. What we found was that this dose of cognitive activities at baseline, so the first time you come to see us, is highly correlated with cognitive performance. And for healthy controls, it's highly correlated to the size of their brain. Remember that concept of cognitive reserve. Okay, so your baseline cognitive and leisure activities actually can predict how you're going to do on cognitive tests and how resilient you are to disease. And it's something that we can modify, we can change over time. Now, if you remember from the beginning, I said one of the early warning signs of neurodegeneration is not memory, it's actually changes in problem solving, what we call executive function. It's very hard to measure executive function. Typically, it takes a very extensive battery of tests. It requires a neuropsychologist, and many of these tests are actually very costly for the physicians to buy, and then, of course, the cost is passed on to you to do this. So what we did was we created a free open access test to do this called the number symbol coding task. So 90 seconds, that's all it takes, 90 seconds. And what we do is we give you a bunch of numbers and a bunch of symbols, and you have to basically solve the code. Okay. And again, what we found is we get a nice distribution of performance, and that this single test by itself, again, can correctly classify 86% of people as having an impairment or not. 90 seconds, 86%. Right? We combined it with the QDRS, remember that test I showed you before, and that gets us to about almost 90% correct classification. So 3 minutes filling out a 10-item questionnaire and 90 seconds doing a coding test, right? 90% of people we can correctly classify. Very simple way of doing this on a research basis, but also these are things that we can translate into clinical practice. We're very interested in other things such as diet. So we use a dietary approach called the MIND diet, which is a combination of the Mediterranean diet and the DASH diet, which was a hypertension diet. And so we have this score sheet so we can look at everybody's diet, and we can do it on these 15 different categories. And depending on how many servings you take, you can get a 0, a 0.5, or a 1. So we can basically put everybody's dietary intake on a scale of 0 to 15. And what we found is that their baseline MIND diet intake corresponds to their cognitive performance, particularly their executive function. Okay. And so this says that we potentially can intervene. And what's really interesting about this is that the group that may be most sensitive to dietary manipulations are the people who are having the mildest of symptoms, that secondary prevention group. Okay. So for physical activity and cognitive activities, it's really the primary prevention group, but for diet, it's the secondary prevention group. So again, by collecting different measurements, we can decide what's the best approach we can take for each group who's coming to see us and participate in a research project, as well as how we're going to do clinical care. Another interesting aspect we've looked at is mindfulness. So mindfulness is basically living in the present moment, right? Not letting the world's weight get, bear you down, load you down. And so we have a scale that we can measure this. And what we found was, in fact, that mindfulness is highly correlated to cognitive outcomes. It's correlated to self-reporting of symptoms. It's related to depression. It's related to cognitive performance, and it's related to your brain volume. Okay, so mindfulness is a very powerful factor. So how do we do this all in research now? So I spent a little bit of time, maybe too much time, talking about how we've developed tools to help us do this. Very important. Try to go and build a house without the proper tools. Not going to be able to do it. So how can you do dementia prevention and brain health without the proper tools? So now we have the proper tools, and we have now the platform by doing very, very detailed assessments of people, looking at their physical performance, their cognitive performance, their health, and not just their brain health, their heart health, their lung health, their eye health, their hearing, their physical fitness. Looking at all of these things together, can we come up with a way of designing a program? So we've done some really interesting things to do this. So for example, your eyes actually are embryologically, so in development, your retina is the same tissue as your brain. So what's ever happening in your brain should be happening in your retina. Now, I can't see your brain readily. I can't look at your brain except through imaging study, but I can directly see your eye. That's what eye doctors do when they look at the fundoscope into your eyes, right? So we can do this fancy tool called optical coherence tomography. Now, ophthalmologists use this to look for glaucoma and macular degeneration, but we are using it to try to look at risk of Alzheimer's disease. And what we found is that measurements of the thickness of a particular area of the retina are highly correlated to cognitive performance and to MRI findings. It takes 10 seconds to do this assessment. 10 seconds. I can make a prediction of what's going on in your brain. How about walking? Well, we've developed this really unique algorithm that's called dual tasking. So dual tasking is basically walking while talking. If you've ever watched people walk and then you start talking to them, you'll find that people slow down. It's a natural process. So you're taking away a little bit of your cognitive load by talking. And so your gait reflexively slows down a little bit, but it shouldn't slow down very much, less than 15%. What we found is people who slow down more than 15%, they likely have some underlying pathology in their brain. And what we found is that looking at dual tasking, we can separate people who are healthy controls from people who have mild cognitive impairment and from people who have Alzheimer's disease and related disorders. So very powerful ways of doing exams and picking out people who are likely to be impaired, okay? And that allows us then to develop interventions. So how do we do this? Well, in our prior lives, we did a study and we enrolled people with no cognitive impairment, that's primary prevention, mild cognitive impairment, that's secondary prevention, and people with mild dementia, that's tertiary prevention. We collected lots of data and we gave them a plan. And we wanted to see could people follow that plan on their own? Because the first step is this even doable? Is it feasible, right? And so I'm going to show you data from the first 104 people that we saw. And so the orange are the people in the primary prevention group, no dementia. In the blue are people with mild cognitive impairment or secondary prevention. And in the green are the people with mild dementia or tertiary prevention. And what we found was doing this plan, just looking at people, collecting lots of data, and then coming up, giving them a personalized plan that they can follow on their own. What we found was in the primary prevention group, 80% improved. Okay, so they were able to actually improve their cognitive performance. In the secondary prevention group, 63% improved. So there was still improvement, although less. However, when we got to the tertiary prevention group, only 20% improved. So again, remember I talked about windows of opportunity, and there are different windows of opportunity based on different people, right? And so for dementia prevention, primary and secondary prevention really lends itself to some of these approaches, whereas tertiary prevention really lends itself to a very different approach, probably much more sort of the medication management, whereas in the primary and secondary prevention, more of the lifestyle management. But lifestyle plays a role in tertiary prevention because 20% of people did improve. And of course, medications play a role in the primary and secondary prevention. So it really just helps us balance out how we're going to approach each person. We found that predictors of decline were the older you are. If you were males, you were more likely to decline. If you had lower education or lower cognitive reserve, you were more likely to decline. And most importantly, if you were more impaired at baseline. So we really want to get to people very, very early in the course of disease. We also found this same approach. We could improve mood. We can reduce inflammatory markers. So we were improving overall health, and that really accounted for a lot of the improvements that we saw. We were also able to reduce stroke risk. So if we use 10% risk as sort of a cutoff for high risk versus low risk, what we saw is that people were at high risk, we were able to lower their risk, and people who started off at low risk were able to keep their risk low. Okay, and this is through a combination of approaches, right? Medical management, risk reduction, behavioral modification, counseling. Okay, so a multimodal approach. This has led us to redesign our intervention. Okay, so this is what the next stage of our program is all about. First is that tertiary prevention probably doesn't work perfectly within this framework. we are developing programs specifically for people who already have cognitive impairment. And we think we have evidence that these can work, right? But when we're talking about dementia prevention, we really can't talk about people who already have dementia in this setting, right? The second thing is adherence is key. What we found is if people don't follow the plan, they don't benefit from the plan. We also want to look at how much resilience can influence the effects, okay? So we want to enroll people with no cognitive impairment, primary prevention, and people with mild cognitive impairment, secondary prevention, right? We want to design our study based on all the information from all those tools that we created. So we can create baseline doses of people's cognitive abilities, functional abilities, leisure activities, physical activities, their diet, their mindfulness. We understand that all up front. We can now make this a personalized plan. And we can enhance it by collecting biomarkers. So biomarkers are biological markers of what's going on in the brain, okay? So we can stratify people not just by the information we collect, but by their pathology, right? And this should allow us to enhance this, okay? And then the personal prevention plan isn't just on your own, it's done with some guidance. So you can meet with a physician and a nurse practitioner, an integrative nutritionist, a physical therapist, a psychotherapist. So you're not just doing it on your own, we're guiding you along the way. So I just want to briefly show you some of the work we're doing with blood biomarkers, because blood is a readily accessible. Everybody's used to giving blood for their doctor's visits. So why can't we do the same thing to look at the risk of Alzheimer's disease? So we're working with several companies to be able to measure amyloid and tau. And what we found is that this particular group, these are people who are healthy controls, but their biomarkers are telling us that they have Alzheimer's disease. That's important because that means that these people fall into that preclinical Alzheimer's group. And we're going to treat these people much more aggressively than people who are biomarker negative. We've been able to take all of these factors now and put them in a single platform, okay? So remember, I talked about the importance of the influence of resilience. We can measure cognitive reserve. We can measure social engagement. We can measure physical activity, cognitive and leisure activities, mindfulness, diet. We can combine this all into something we're calling a resilience score. Okay? And what we find at baseline, that there's a significant difference in the resilience scores from people that would be in our primary prevention compared to our secondary prevention. And people are different in their secondary prevention compared to tertiary prevention. So we can personalize the prevention plan strategy for you based on your individual risk factors. This resilience score gives us a normal distribution, a wide range of values. So each person can be thought of as an individual rather than just grouping everybody together. There are people with low resilience and there are people with high resilience. The intervention for a high resilience person is going to be fundamentally different than an intervention for a low resilience person. This is a new project that's funded by National Institutes of Health, where we're going to be looking at trying to determine the population-based prevalence of cognitive impairment in the state of Florida using an online evaluation, and then have people come in for more detailed assessments, okay? And then using hopefully philanthropy and donations, develop this personalized prevention plan, right? So that a smaller group of people will have this primary and secondary prevention intervention. This platform works really well. So we are able to take our brief tools that we created and we could discriminate healthy controls from people with mild cognitive impairment, with people with Alzheimer's, people with Lewy body dementia, people with vascular dementia, people with frontal dementia. It works across the board. So very, very powerful tool. And the last thing I just want to say is that we collect a lot of information. We collect so much information and our sample size will be big enough that we can actually start to use what's called artificial intelligence or machine learning techniques, where we can actually take the data we collect from MRIs and from PET scans and from our blood test and from our genetic test, right? And we can extract features from each of these, right, to basically come up with a classification. And this is going to help us fine-tune this precision medicine approach to dementia prevention in a way that's never, ever been done before. So to summarize, there may be multiple pathways to Alzheimer's disease and related dementias. If there are multiple pathways to get there, that means that there are multiple pathways that we can treat, prevent, or cure disease. And we think there's an optimal window to do this. We think that optimal window is best when we do multimodal approaches, looking at at-risk individuals based on their personalized risk profile, and that it's guided by biomarkers. We think if we wait too long, then the window of opportunity gets smaller. So we can still do things, and we are going to do things. But this broader strategy, we really need to get people early. We need to get them involved early in research so that we can try to do this and prevent people from ever developing diseases like Alzheimer's disease. Precise measurement is really critical, and we've developed the tools to do this. We are the only lab that has these tools in place to do this. So our personalized prevention plan really moves away from this one-size-fits-all approach to target it specifically for you. An ounce of prevention is worth a pound of cure. Benjamin Franklin, 1735. I really want to thank you for your attention. I have the opportunity and the fortune to work with an amazing group of individuals at the Comprehensive Center for Brain Health. You'll get to meet a lot of these individuals in the video, and we're available for question and answers. If you're interested in participating in one of our research programs, please contact us. If you're interested in helping us fund our research programs, please contact us. If you're interested in being part of our auxiliary or spreading the word about dementia prevention, please contact us. You could reach us at our email at healthybrain@miami.edu. Thank you so much for your attention. I look forward to meeting you in person at our center. Thank you.
Okay, so it's been about a 5-minute little brief intermission here. We're returning now, so thank you all for returning back to us. Hopefully we all were able to get up out of our chairs, attend to some personal business. It's good to have you back. Okay, so I wanted to get started on some gentle beginner Tai Chi moves. This is meant to be easy and can be done sitting or standing. I'm going to be standing, but you can choose either one. Tai Chi is a wonderful way of centering ourselves. So it encourages mindfulness and body awareness, being present in the moment, and Tai Chi forms seek to create inner balance. There's yin and yang, dark and light, feminine and masculine. They are opposing forces, but complementary. You can't have one without the other. And Tai Chi balances and encourages the flow of Qi. So Qi is our life force. It's the energy that flows through us. And it uses slow, deliberate movements. So let's start with feet planted. So put your feet on the floor, both feet. Spine straight but relaxed. I'm going to stand and bear with me as I go through the moves. I will be explaining them and guiding you through them verbally. If my hands disappear into the Zoom background, then just follow along. So first thing that we're going to do is some breathing. So you're going to take one hand and place it above your belly button. Take your other hand and place it below your belly button. And we're going to do some diaphragmatic breathing. This is basically just belly breathing. And what you're going to do is feel your stomach move, especially as you breathe out. So slow in through your nose, slow out through your mouth. And it's okay if we're not all in sync together. We're going to probably do about 3 breaths. So here we go. Slow in through your nose. Slow out through your mouth. You should feel your hands moving as you breathe. Feel your stomach moving in through your nose and out through your mouth. So now, hands at your sides. We'll start with that. Next, what we're going to do is play with our chi. So we're going to work with our chi with our hands. So we're going to put our hands in front of our bodies, one hand on top of the other, palms facing each other. And what we're going to do is just shift our hands, palms always facing each other. Shifting our hands. It's like you have a beach ball between your hands. This is a ball of energy. This is your chi as you slowly work with it. And this should be in front of your belly, in front of your chest. Like this. Now what you're going to do is you're going to take your hands and you're going to place them at either side, palms facing each other, and we're going to pulse in and out 3 times. Like that. In and out. Okay, arms at your sides. Next, what I want you to do is we are going to do a movement that is really good for stretching. And if you have been spending a lot of time on Zoom or staring at a computer screen for a while, this is just a great stretch to do. So I'm going to stand at the side so you can see me. And we're going to put our arms at our sides to start. And we're going to lift up slowly, slowly, slowly. My palms are now turning up towards the sky. And I'm going to bring my palms in towards my face, in towards my chin, and tuck my chin in and push away. Let's do that again. Palms up towards the sky, bring them in towards your chin, tuck your chin in, and then push away. One more time. Palms facing the sky. Bring your palms in towards your chin, tuck your chin in, and then push away. We're going to drop our hands at our sides. This last form that we're going to do is called parting horse's mane. And it's another really good one if we've been sitting for a while. Helps to stretch the spine. So we're going to start in that position again where we have our chi, our ball of energy is between our hands. And we're going to move and rotate our torsos, bringing our hands so that they're facing us, one hand. Go about 70%. Now what we're going to do is go to the other side. So bring your hand up so it's facing you. You're going to come back down. You're going to switch. Do it again. Rotate. Go a little further this time. Just turn your spine, stretch your spine out a little bit more. Great. Again, rotate and twist. Stretch it out. We're going to do one more on each side, okay? So here we go. Nice and slow, controlled movements. Stretch that spine out. Again, we're going to go with our hands facing us, twisting. All right, that was the last one. We're going to put our hands at our sides. We're going to conclude working with our chi one more time. So hands facing each other in front of your chest, in front of your stomach. I'll go from the side here so you can see me. And we're going to pulse in and out 3 times. Ready? 1, 2, and 3. Arms at sides. Okay. Well, I hope that was beneficial to everybody. I hope you all got something out of it. And we're all in a good mindset now. So we're going to transition now to the next section of our webinar. We're going to now meet the Comprehensive Center for Brain Health team. And after that, we'll have a live Q&A. But first, let's meet the team.
My name is Dr. Stephanie Crisfont, and I am a Research Assistant Professor of Neurology and the Associate Director of Operations.
My name is Magda Tolea, and I am a Research Assistant Professor of Neurology at the Miller School of Medicine and also Associate Director for Research at the Comprehensive Center for Brain Health.
Hi, I'm Marcia Walker, and I'm a board-certified nurse practitioner in Dr. Galvin's CCBH Department of Cognitive Neurology at the University of Miami.
My name is Carrie Greenfield, and I am a licensed adult geriatric nurse practitioner in neurology at the University of Miami Miller School of Medicine.
I'm Iris Cohen, and I'm a social worker.
As the nurse practitioner at CCBH, I work primarily in the diagnostic clinic. My primary role is to provide concierge-level care to all clinic patients and their families.
At the CCBH, I am involved with initial patient diagnosis, follow-up appointments, psychotherapy, and some research project the center is involved with. So my main interest is the effect of behavioral modification on our patients' population's quality of life and disease progression. Supported by research, these modifications include healthful eating habits, regular vigorous exercise, staying socially active, and good mental health. What I'm most proud of are the support groups that I have designed within the framework of mindfulness-based interventions. They provide the caregiver and patients with safe space where they can talk, gain tools and education that they can employ to deal with difficult challenges they might be facing.
I am the founder and program director of CCBH's Integrative Nutrition Health Coaching Program. My program serves to empower clients to make positive lifestyle changes. The goal of my program is to optimize brain health. After identifying each client's imbalances in diet, sleep, mood, to name a few, I tailor an individualized wellness program for each client. Upon the completion of Dr. Galvin's first initial diagnostic evaluation, I have the primary responsibility of maintaining follow-up care for the clinic's patients. In those follow-up visits, I will have discussions with the patients and their families. We will go through medication review and management. I will perform cognitive evaluations, neurological exams, and nutritional assessments, as well as any other assessments that may be needed. I manage mood disturbances, behavioral disturbances, and sleep disturbances. I provide emotional support along with education to the patients and their families. In addition, I will refer patients and families to community resources as needed.
Here at the University of Miami, we are looking forward to collaborating through research and clinic and supporting you through your journey to achieving a healthier brain.
My name is Chanel Disla. I'm a Senior Clinical Research Coordinator. I'm currently involved in the Digital Detection of Dementia Research Project, also known as the D3 study. The focus is on effective approaches for early detection for Alzheimer's disease and related dementias. The D3 project is a multi-site collaborative endeavor that consists of 2 complementary studies. The first is a clinical validation of 3 scalable approaches in identifying Alzheimer's, and the second includes a pragmatic cluster randomized controlled trial of 2 early screening approaches for these diseases. When used with electronic health record systems, we can help support the mission of developing low-cost early detection and treatment of Alzheimer's disease. There is a one-time visit to our research clinic that will include a medical record review, a physical and neurological examination, and a variety of scale assessment used for cognitive screening. We are currently looking for volunteers that would like to participate in the study that meet the following criteria: are 65 years or older, are English or Spanish speakers, have had at least 1 visit to their primary care practice within the past year, and have been with their primary care practice for the past 3 years. We look forward to working with our local community of physicians, patients, and caregivers alike with the development of effective early disease detection methods. If you are interested in participating in the D3 study or finding out more about brain health research, please contact us at healthybrain@miami.edu.
My name is Susan Ron, and I'm a research nurse coordinator. There's an urgent need for more effective treatment options for Alzheimer's disease. Currently, I'm working on the Lucinda trial, which compares an investigational agent to placebo in subjects taking Aricept. There's evidence to suggest that this drug, when combined with Aricept, may slow cognitive and functional decline. Study participation is expected to last 14 months, with a visit to our office and injections 4 times during that period. We will follow you closely with blood tests, questionnaires, cognitive tests, MRIs, and PET scans. We're recruiting women over 65 years of age who are taking Aricept. We look forward to seeing you at the Comprehensive Center for Brain Health.
My name is Claudia Moore, and I am a Senior Clinical Research Coordinator.
I am Mary Lou Riccio, and I am a Research Nurse Coordinator.
I am currently involved in the Multicultural Dementia Screening Study as well as the Healthy Brain Initiative.
I am also involved in the Healthy Brain Initiative and a multicultural study for South Florida's rural population. All of these studies are aimed at prevention and early detection.
For the Health Brain Initiative and Multicultural Study, they're both looking for participants age 50 and above, independent living, English and Spanish speaking.
For the rural study, we are looking for participants ages 60 and above, independently living, English and Spanish speakers who live in the western part of Palm Beach and Broward counties.
These particular studies are all observational. For the Multicultural Screening Dementia Study, 2 annual visits, a study partner, and labs are required. For the Health Brain Initiative, it's a longitudinal study with annual visits, labs, and brain imaging.
The rural study has a one-time visit, memory tests, health surveys, and either blood work or saliva to test for genetic risk factors.
Participants are required to come to our clinic, whether it is for a biannual visit or annually up to 5 years for the longitudinal study.
The rural study has a virtual visit that can be completed from home.
We look forward to seeing you at the Comprehensive Center for Brain Health.
We look forward to seeing you at the Comprehensive Center for Brain Health.
I'm Judy Simon, and I'm a Community Outreach and Creative Arts Coordinator.
I'm Connor Galvin, and I'm a Research Assistant.
Hi, I'm Dr. Amy Rosenfeld. I'm a physical therapist researcher. My interests are examining non-pharmaceutical interventions to prevent cognitive decline. Prior projects that I've been involved in looked at interventions such as chair yoga and acupuncture and their effects on the symptoms of cognitive impairments. I'm interested in investigating how exercise can be an effective intervention in neurodegenerative diseases and also how physical function measures can be used to screen for cognitive function. Well, I've been practicing as a physical therapist for over 17 years. At CCBH, I perform cognitive screens for our research projects, but I also do physical function assessments that include gait, balance, and strength for our clinical trials and also for our diagnostic clinic. In the future, I plan on conducting trials at that investigate the effects of exercise, more specifically dual tasking exercise, such as talking and walking, or conducting calculations while sitting to standing, and how those exercises affect brain health. That includes balance, cognition, and gait. I look forward to expanding our knowledge together and working with you and our team to give you the keys to unlocking a healthier brain.
I'm Dr. Michael J. Kleiman, data scientist and postdoctoral fellow. My role at the CCBH is to examine medical and behavioral data using statistical, machine learning, and deep learning techniques. I also develop research projects that involve finding more efficient and accurate methods for detecting cognitive impairment. One of my projects that will soon be ready is a brand new style of cognitive assessment. Most of the time, when you go to a neurologist or neuropsychologist for testing, you are asked to remember a few words or a few sentences or even do some light math. Even though these are very simple, they're also very useful for detecting cognitive impairment, due to their ability to measure the types of thinking that become most affected when dementia is developing. My approach is to simply ask you to watch a series of pictures and videos on a computer screen, while I measure where on the screen you're looking. Occasionally, you will also need to read a short passage or answer an open-ended question about what you're looking at. That's it. There are no wrong answers, since I'm more interested in how you take the test. If you're above the age of 70, We're especially interested in your participation, but we would appreciate your help no matter what age you are. If you are interested in this or any of the other studies discussed today, please feel free to contact us and let us know. You can reach us by email at healthybrain@miami.edu. We will also be sending out a link to a survey that will let you choose from all of the opportunities that we currently offer. We would very much appreciate your participation. Without your help, our research into healthy brain aging simply wouldn't be possible. Thank you all for your attention during this webinar. We will now hold a brief Q&A session so that we can answer your questions. And once again, we look forward to seeing you at the Comprehensive Center for Brain Health.
We look forward to seeing you at the Comprehensive Center for Brain Health.
At the Comprehensive Center for Brain Health.
We look forward to seeing you at the Comprehensive Center for Brain Health.
At the Comprehensive Center for Brain Health.
At the Comprehensive Center for Brain Health.
We look forward to seeing you at the Comprehensive Center for Brain Health. Thank you, team. That was fantastic. All right, so now we're going to open up the live question and answer session. First of all, I want to say we appreciate your overwhelming interest. We are grateful for all of your thoughtful questions. We're going to try and keep the Q&A to about 15 minutes. All of the questions will be addressed in some way. So if we don't have time to get to your question in today's session, we will be emailing you each with all of the answers in a document in a follow-up email, so look out for that. We can also include a link to the video, again, as I said, as this is a recorded session, so you could have a link as well to rewatch the webinar. And again, if any questions come up between now and anytime in the future, you can always contact us at healthybrain@miami.edu. Okay, so we're going to get started with some questions here. Let's see. The first one I have looks like a good one for Dr. Galvin. It says, does cognitive activity, regardless of which one, act the same way in everyone? Does enjoying the activity have any extra positive effect?
Well, that's a great question, and thank you for asking it. We're very interested in how cognitive activities, physical activities, diet, exercise, lifestyles impact brain health. A lot of what we're trying to do is to try to figure out exactly what the correct dose, and I use dose in quotations because these are research questions that we don't know the answers to. A lot of what we've done is develop tools to help us capture this. And one of the things we're interested in, again, as I mentioned during the lecture, if you play bridge or you read a book or you go to a concert, or if you do all of those things, is there a minimal dose that's really needed to promote brain health? We think that there is a minimal dose, and by increasing people's activities, we might be able to provide protection against neurodegenerative diseases and reduce the decline in people who have symptoms. But what we're not sure right now is there one activity that's better than the other, and that is an area of active research within our group.
That's great. Thank you, Dr. Galvin. We have another question for you. It looks like the question is there any usefulness of spinal fluid in workup of dementia?
Another great question. So one of the things that is very of great interest in brain research is something called a biomarker. So a biomarker is some biological marker that can look at the pathology depositing in the brain. And there are three basic ways that we can capture biomarkers. One is through blood test, two is through spinal fluid done by a lumbar puncture or spinal tap, and three is through imaging studies, either MRI or nuclear medicine PET scans. All three ways we can capture measures of the pathology in the brain. They each have their pluses and minuses. So blood is the least invasive, but right now is the least developed of all of those methods. Spinal fluid is probably the most invasive, but gives a lot of information that you can collect all at one time. Imaging studies are not invasive, but the most expensive way of doing it, and you can only capture one biomarker at a time. So for each study, there are pluses and minuses. our approach is largely focused on using blood markers complemented with imaging markers, because in our experience, people are not as interested in doing spinal taps for research. For clinical purposes, there are approved tests using spinal fluid. There is now an approved test for blood. And of course, there are approved tests using PET scans. So each of these can be used in clinical settings for diagnoses.
Okay. So here's another question for you, Dr. Galvin. What is the difference between Alzheimer's disease and dementia?
Wow, really great question. So dementia is really a general term. It's describing a change in memory and other thinking functions, but there could be lots of different causes of dementia. Alzheimer's is the most common cause of dementia. So all Alzheimer's is dementia, but not all dementia is Alzheimer's disease. There are over 150 different causes of dementia, which include Lewy body dementia, vascular dementia, frontal temporal degeneration, traumatic brain injury. So lots of different causes. They each have different symptoms. They each have a different clinical course. They each have different underlying pathologies. One of the things we're interested in is trying to figure out what are some of the risk factors for these different types of dementia and what we can do to try to treat, prevent, or cure these syndromes.
All right. Here's another one for you. If I already have Alzheimer's disease, will any of the prevention actions help?
So we talked a lot about prevention during the talks today. But in fact, we have lots of evidence that all of these things can help reduce some of the symptoms or slow some of the symptoms that occur. So no matter what stage people are in, we can do things for them, and we have programs we're developing to help you. So there is evidence that exercise and dietary approaches and cognitive activities and social engagement can all reduce some of the burden and symptoms of disease, but they don't change the underlying disease. So it depends on where you're coming to us, what program is the best for you, whether we're doing that primary, that secondary, or that tertiary prevention.
All right, great. Thank you, Dr. Galvin. Here's a question about research. It says, I want to participate in research, but I'm concerned about my information being linked to a study. What do you do about that? And Dr. Talea, she's our data manager, a gerontologist, a research assistant professor. Would you like to take this, Magda?
You're on mute.
Go ahead and unmute. Yes, I'm sorry. Yes, thank you, Amy. Let me just a second. So we are very careful to protect the privacy of all of our research participants and patients. And that is why each individual is assigned a unique encrypted ID number so that only Dr. Galvin and myself as the data manager can access the full data set. So your information cannot be linked back to any study or identified by anybody else outside of our research group, or even within our research group, really. All of our protocols follow the latest requirements on data protection and HIPAA law and are reviewed and approved by our institutional review board.
Okay, great. Thank you, Magda. Here's the next question. My spouse already received a diagnosis, but we want to be under your medical care. How do we do that? So this question is about clinics. So Carrie Greenfield, our nurse practitioner, she provides clinical services at CCBH. Would you like to take this one?
Sure, thank you, Amy. So it's a great question, and I'm sure by now there are many other listeners who are wondering the same thing at this point. So as you already know from spending some time with us this morning, we are largely a research center. But that being said, we do offer comprehensive clinical care opportunities for those of you that are seeking that. So here's how it goes. We would ask each and every person who is interested in our center to enroll in one of our research projects. When you enroll in one of our projects, you will receive a detailed evaluation, at absolutely no cost. At the end of the evaluation, we will provide you with written feedback on your results, along with recommendations that you can share with your healthcare provider. If you wish to be under our medical care, It would be our great privilege to care for you, and an appointment with one of our clinicians will be made for you.
Thank you, Carrie. So here's a question about lifestyle. This one's for you, Dr. Galvin. It says, the things you talked about, diet, exercise, cognitive activities, are these things I can do on my own, or do I have to participate in research?
Well, many of these things probably your doctors have been telling you about your whole life, and they make sense, right? To stay mentally active, physically active, socially active, eat a healthy diet. These are things that people should be doing on their own. The fact is, however, we're not particularly good at doing it on our own. And so a lot of our projects are based on first determining what your baseline activities are, two, what's the right dose of activities that might be beneficial for you in the future, and then participating in the projects. And participating in the projects actually sort of holds your feet to the fire a little bit. And so coming in and being evaluated, people probably under supervision are more likely to follow through with some of these things. And as I said, adherence or following through with the plan is really key. If you don't follow through with the plan, you don't benefit from the plan. So you can do it on your own, and I encourage people to do things on their own. But we have found that in the research program that sort of the supervision really does add another layer of control over trying to see whether these things have beneficial effects.
Okay, here's the next question. I want to participate in support groups. How do I sign up? Iris Cohen, our clinical social worker, she's probably the best person to answer this one. So Iris, do you want to go ahead and take this?
Sure, thank you, Amy.
Yeah,
so we offer several different types of support groups, but we also collaborate with other organizations that provide support groups that we do not specifically offer. So for example, the Association for Frontal Temporal Degeneration or Lewy Body Association, which I work very closely with, the Alzheimer's Association, or the American Parkinson's Disease Association. This allows us to offer support to a wider range of individuals. So please, for additional information, reach out to me at healthybrain@miami.edu, and I'll be happy to provide you with links. Thank you.
All right, Iris, thank you. The next question says, my husband takes Aricept and Namenda. Is there anything better he can take? Carrie, can you take this one?
With pleasure, thank you. So as a healthcare provider that doesn't know your husband yet, I can't speak specifically on your husband's behalf, but what I can say more generally is that currently we have 4 approved medication for Alzheimer's disease. And at the present time, Aricept and Namenda are, of course, 2 of these medications. We believe that these medications absolutely provide symptomatic benefits. Patients have to be on the correct dose at times, take them as directed, and as Dr. Galvin has mentioned a few times today, of course, be compliant. So in addition, our approach also incorporates several lifestyle factors, which you've heard many of today. Our focus in clinic is to integrate both the pharmacological aspects and the non-pharmacological aspects to make you the best version of yourself.
Okay, great. We got another question about medications. Are there new medications coming anytime soon? Dr. Galvin.
So there, as Carrie recently mentioned, there are 4 approved medications. There have been no new approved medications for almost 20 years now, but there are lots of trials ongoing. Over 150 clinical trials are ongoing, testing different agents. You may have heard about one more recently, a therapy called aducanumab, which completed its studies and was reviewed by the Food and Drug Administration. Its application is under review. Last week or so, the Alzheimer's Association came out in favor and in support of the application, encouraging the FDA to approve. The FDA has until originally March, but FDA just recently released that they're going to ask for some more data and some more data analyses. So they have until June to make a decision. We are hopeful that this medication will be approved, and we believe that it would greatly add to our bag of tricks in order to help people that are affected with Alzheimer's disease. So we're looking forward to hearing more in the next coming months.
Okay. What information can I expect to receive? This is about research. So what information can I expect to receive after my research visit, if any? We've got Marcia Walker, our nurse practitioner here. Do you want to go ahead and answer that?
Sure. Thank you, Amy, and thank you to everybody who has spent their morning with us. We greatly appreciate it. So at the completion of the visit, a clinician will provide very useful feedback information for each participant. The summary findings will be included in that feedback, including physical exam findings, such as vital sign measurements, which include blood pressure. We would also just explain, whether or not we've seen a cognitive impairment versus normal cognition. And if a cognitive impairment was identified, we discuss the domains in which the challenges were noted. We provide preventative implementations and resources for mindfulness activities and cognitive preserving information as well. We give recommendations for overall health, and we make necessary referrals as we see fit. So we provide a significant amount of feedback and tools and resources that are actionable in hopes that each participant applies those recommendations to their overall lives in their daily life activities to increase their health. And as Carrie mentioned, you can take this feedback form to your established provider who can decide to implement this information into your plan of care.
All right, so I think that participants will find that that is a great tool, something that they can take action to improve their health. So that's great to know, Marcia. Thank you.
Absolutely, you're very welcome.
We're starting to run out of time. We're at 11. We're almost at 11:30 here. Let's address maybe one more question if we have some time. A lot of you are asking how to reach us, so and how to kind of see us at our center. So I think I'm going to address this last question while we have time to Stephanie Crisfanti. She's our research assistant professor of neurology, associate director of operations. The question is, I am interested in participating in research at your center. What's the next step? So go ahead, Stephanie.
Hi, Amy. That's a great question. I know you guys are really interested in getting in contact with us. And the easiest way to contact us is through our email address, which is healthybrain@miami.edu. That's HEALTHYBRAIN@miami.edu. And you would send us your name, your age, your email address, and the easiest way to contact you. And someone from our team will be in contact with you within 2 business days. This will kind of help us figure out what is the right research project for you so that we have a good fit. Okay, so that email address again is healthybrain@miami.edu.
Thanks, Stephanie. All right, so it has been an absolute pleasure to have you all here with us today. We truly appreciate your attention, your interest, and your questions. Again, we will be emailing you answers to all of them if we didn't get around to them today. So look out for that. We will also be sending you a survey, a post-webinar survey. So look out for that as well. Please be healthy. Thank you. And we look forward to seeing you at the Comprehensive Center for Brain Health.
Thank you. Bye-bye.